Okay, thanks everyone for joining us for day 9 of the QMS course hosted by Pathologists Overseas and ASCP. Today we have Dr. Tim Amakili, who is actually our PO lead on the course and is going to talk to us about external quality assessment and EQA, etc. Before we do that, remember, if you have questions, please use the Q&A box to the bottom at the right. If you have a technical problem, please use the chat box to the left. And as always, this is being recorded and will be available on the landing page within about 24 hours to review if you have not, if you missed part of it or if you get knocked off the internet, etc. We will be doing some cases. Dr. Amakili sent those to you previously. I know some of those were a little bit delayed in getting to you, but hopefully you'll have them in front of you while he's talking. And then we will do Q&A throughout and at the conclusion. So with that, I will turn it over to Dr. Amakili. Thank you.
Hi, everyone, and welcome. Today's course is about external quality assurance, which we sometimes call proficiency testing, but that's not all it is. I'm really looking forward to giving this talk because I will start by talking about external quality assurance and the three flavors it comes in, and then I'll spend much of the talk focused on proficiency testing, including the history of it. And I'm hoping that it will be helpful to those of you in the course to learn about how proficiency testing became part of laboratory practice, and also the kind of the evolution of quality in the United States system, because I think it will actually be informative and encouraging, actually, to see that other societies started somewhere and have improved. So at the end of this lecture, you'll be able to discuss the importance of an EQA program in improving quality of laboratory test results. You'll be able to describe the history of proficiency testing. You will be able to list 2 reasons why PT performances tend to be much better, pass rates much better in Western countries. You'll be able to outline the steps in participating in an EQA program, from enrollment to investigation of an unacceptable result. And you will be able to read and interpret a CAP, that's College of American Pathologists, proficiency testing results sheet. All right, this is one of the 12 items in our quality management system, and I think it's a really important one. In fact, in SLMTA, to make it to step number 1, you have to have, there are 2 quality indicators you have to have, and that's QC and PT, proficiency testing. So we'll start with a definition. What is external quality assessment? And it is a system for objectively checking the laboratory's performance using an external agency or facility. Now, this can come, as I mentioned earlier, in 3 flavors. It can come as rechecking and or retesting. It can come as an on-site evaluation, and it can come as proficiency testing. We'll touch on the first 2 briefly, and then spend most of the lecture on proficiency testing, because that's the most common, and I would say the most deployable and probably effective method. Maybe not effective, but the most deployable. So rechecking and retesting involves the sharing of samples, with a reference lab. And this is actually often done, like in the cases of HIV rapid testing, where or TB, actually AFB, where the original test is done by a local lab for the purposes of having better turnaround time, TAT, but then ultimately all the samples are sent to a reference lab and they are repeated. Sometimes it's done by sampling. That's called rechecking, when you don't do everything, but you may, for example, only do a 10% check, or only retest the positives and 10% of the negatives, or that kind of thing. So it's something that's used fairly often, especially with AFB screening. It's also used with a lot of malaria screening, and it's quite effective. However, on-site evaluations tend to be even more effective. The problem with on-site evaluations is that they require a lot more resources, both from the inspector's point of view as well as from the inspected person's point of view. From the point of the inspector, they have to travel and come there and so forth. And from the point of view of the lab being inspected, it's also a much bigger event and causes much more disruption in day-to-day practice. Okay, so let's go here. This is a paper that compares the impact of a rechecking versus on-site monitoring. So this was this paper came out of a program in which there was already a rechecking system. That's the before column. And then once they started doing on-site inspections, it shows you what happened. So you can see most things improved. So for example, many of the labs, most of the labs, 96% did not have a sand bucket. And afterwards, most of them did. So only 27% did not afterwards. 60% were not decontaminating sputum cups, which is really important for AFB TB testing. And after the site visit, only 23% were not doing it. And so this chart basically shows that a site visit is very, very effective. However, it requires a lot more resources. Here, this table is talking about that very issue, comparing proficiency testing to rechecking. And if you go all the way to the bottom, so it starts with interlaboratory comparison and so forth. But if you go to the close to the bottom of the slide where it says time and resources needed, you can see that a PT system where you just get samples coming to the lab requires a lot less time and resources than a rechecking system or on-site visit system. You can also scale more easily. When you look at analytes evaluated, you can analyze many more with a PT system than with a rechecking system. And so this is why PT systems are more common because they're more scalable and require less time and resources. All right, so now we will switch to proficiency testing. And I will spend the rest of this lecture talking about proficiency testing. As I said in the beginning, I will do a few general slides about proficiency testing, but I think most people on this, listening to this lecture have some idea about it. And so I won't spend too much time on that. I will spend more time showing you actual proficiency testing reports and what they look like, and as well as investigation reports. And then I will spend quite a bit of time talking about the history of proficiency testing, because I think you will find it really, really useful. All right.
We have one question on the retesting. It's can you clarify what the difference is between retesting and rechecking?
Yes, it's about scope. So a retesting assumes that you're doing 100% of the work again. So all the work gets read at the local lab, and then all gets sent to some reference lab, and the lab repeats all the work. And it's less common now, but I would say in earlier times with rapid HIV testing, that was the method. And then rechecking is a random selection of a small amount, usually 10% of tests that are retested. So retesting is 100%, rechecking is some smaller number, say 10%. Okay. So proficiency testing, the CLSI describes it as a program in which multiple samples are periodically sent to members of a group of laboratories for analysis or identification. And each laboratory's results are compared with those of other laboratories in the group or with an assigned value and reported to the participating laboratories and others. I think that's a pretty good definition. I just put this slide in to remind us that it's required. EQA participation, PT participation is, to my mind, one of the most important things we can do for quality, and is recommended for all labs, but it's actually required by ISO and also by CAP. So whichever route you take to become accredited, it will be required. Okay, so here is just the kind of, let's see, 5 steps for a proficiency testing process. The first step is to enroll in some proficiency testing schemes. There are many local ones throughout sub-Saharan Africa, but there's also UK NECAS, which is quite popular. There's all the ones that the College of American Pathologists deploy. And then there are many other groups. There are some EQA schemes that are local. There are some that come from, I know that Pathologists Overseas supports some EQA proficiency testing labs with materials from the Royal College of Pathologists of Australia. So the first step is to enroll. Second step, when samples come, treat them the same as a patient sample. So whoever's on the bench, have that person run those specimens. Also, no consultation with outside laboratories. That's considered a breach of appropriate practice. Basically, it's cheating. And then number 4, which is the big one, is investigate deficiencies and make corrective efforts. In my experience, this has been the problem that we see is many labs are happy to enroll, but they don't go back and investigate deficiencies and fix corrective efforts. We didn't have time today, so I'm not sharing it, but I have something like 8-9 years of PT data from different labs that Pathologists Overseas has supported. And the majority of labs do not then go back and fix the problems. This is what seems to be the hang up. What we have learned though is when we come in and talk with labs and sort of push them to do the investigation, then they do it and the improvement happens, but it doesn't naturally happen. And I've spent a lot of time thinking about it. And when I get to the discussion of why PT performance is so much better in the US, I will share some of those ideas, and I'll be interested in your feedback and opinions. Last but not least, keep records. Okay, so that's the overall overview. Now I'm going to go to an actual PT report, because I thought this would be more useful than just discussing theoretically. So I've put here, go to FH10C PDF, which came to you in an email. But if you don't want to skip, move away from the screen, you can stay on the screen, because I will be sharing it on my screen. So when you look, is there a question, or should I keep going?
We have a couple technical issues. The only other question right now is, what's the difference between external quality assurance and external quality assessment? Are they used interchangeably?
Yes, they are. They're used interchangeably. Yeah.
So
all
that's
right.
it for questions right now.
Okay. So I did some screenshots of the PDF, but let me, if you don't mind, let me pull up the actual PDF here. So here it is. Okay. So you are seeing, this is the report you get from the College of American Pathologists when you register for their proficiency testing schemes. Each report is different. So for UK NECAS, it's a different kind of appearance. But one thing you always have is you have the administering group, whoever's administering the EQA, you have their name on the top left corner, which is here is College of American Pathologists. And below that, we have something that says FH10C. So FH10 is the challenge. So in this case, it's hematology. And C tells you which cycle you're on. So for 2020, we get 3 cycles, and this is the 3rd one. Okay, so
Tim, your screen isn't showing the EQA report right now.
Oh, okay.
You might be sharing the window, but not the screen.
Okay, so let me, if you don't mind, let me go into, I think I have to stop and start again. Screen sharing, sorry guys, let me do that. Let's say new share. And then how do I say window? So I'll just say screen. Can you see it now?
Yes, we can see it now.
Okay, great. Okay, so on the top left-hand corner, you see the, and now you can still see it?
Yes.
Okay, on the top left-hand corner, you see College of American Pathologists. That's who supplies the EQA. And then here you see FH, I don't know if you can see my cursor, but I'll highlight it. You see FH10-C 2020. And what this means, FH10-C is whatever this is, just a way of identifying what this EQA is about, what this PT is about. So in this case, FH10 refers to hematology autodifferentials. And the C refers to which cycle it is. So this is the third cycle in year 2020, okay? And you can see down here which lab it's for. It's for the Infectious Diseases Institute core lab in Kampala, Uganda. So I served as the medical director for this lab for 6 years, and this was some of our EQA from last year. And you can see here the date the kit was mailed. You can see it was mailed in September to us, and we submitted our evaluation in the next month, the October 21st, and the next one is coming in January, and so that will be cycle A for 2021. Okay, so that's how you read this first sheet, and then as you go down, you have where it's reviewed, who reviewed it, and so forth. So usually what happens is, so because I was the director for this lab and the lab was in Kampala, they would send it to me by email and I would review and sign it and send it back. And if you're present there in person, so for example, at Bayview Hospital, at Hopkins, I would just, I had a weekly meeting with my manager and I would review these and sign them. So that's the identifying information. And then here is what the form looks like. What I will stress is that for every different EQA supplier, this will look different. But for all of them, they contain a lot of information. And so I'll just go through the one for CAP, for CAP, and I hope that it will be useful to you. So let's go back in here. So on the top, on the left, we have, so this sheet is broken up into 3 columns. The one on the left, the one in the middle with the numbers, and then the one on the right with sort of colors and bars. And each of these contains different type of information. So on the left, we have the name of the analyte being tested. Here it says white blood cell count, right? So that's what's being tested. And then the second row says red blood cell count. The one after that says hemoglobin. The one after that says hematocrit. So those tell you the analytes. And for each analyte, we have 5 challenges. So these are 5 samples that were mailed to the lab that were blinded, that we could not see, and that we tested blind and sent our results. Now, this middle section is broken up into 6 rows. So the first one just tells you the specimen ID. So it's specimen number 11, number 12, number 13, number 14, number 15. And notice that for red blood cells is the same 5 specimens, right? So you get 5 specimens for each analyte, but basically it's the same one tube. It's the same FH1011 that's run for all these analytes. And our results, the first, this column says our result. Our result was a 9.2 with a mean of, the overall mean from all the labs was 9.19, so we were right there. The standard deviation is 0.31, and there were 99 labs that were included in this PT. So there were 99 labs that ran the CAP PT that also used this platform, the Coulter Act diff. And our STI, which just tells you how far you are from the target, was 0. 0 is great in this case. You can see that we drifted far away for some other ones. So this is plus 3.4. And then it tells you what are the ranges. So for that sample, the mean result was 9.19, or let's say 9.2, but the range is 7.8 to 10.6. So anything in that range would be considered acceptable, and we are considered acceptable, okay? And same way for all the rest of them. you can see that for sample FH1015, our result was 5.3 and the mean was 4.8. So we're quite high, but we were still within the range here. It's because we were not higher than 5.6. Okay, so that's how this is interpreted. And then when you get over to the left side here, this shows you different information. Can you see that I zoomed into it? Does that work on your end?
Yes, we can see that.
Okay, great. All right, so this shows you the results for a whole year. And it is a way to kind of tell what is happening with your analyte. So remember that this whole result sheet we're looking at is for FH10C in 2020. And that is shown here as the most recent one, right? So all these 5 results that we were looking at are all packed in to this top row. Okay, and then below that, but below that, we have the results for cycle B, which was like the middle of the year, 2020, and for cycle A, which was the beginning of the year, 2020. And what this allows you to do, it allows you just by looking at this figure to know that overall for the last year, we have been running a little, we have been passing, but we've been on the high side of passing, right? So that's why all the bar graphs are sort of leaning to that side. And you can see when you look here, when you compare our results here to the mean results. So this is our results. Come on. Okay, our results to the mean. You can see that we are here. We're the same. The next one, 16.4, 17.3. We're lower, but mostly we're higher. So 4.1 is higher than 3.8. 24 is higher than 23, and 5.3 is higher than 4.8. So we have the same pattern where we're running kind of on the high side, and we've had it the whole year. So this allows you to say, okay, our platform for white cells seems to be running a little high, but we're still passing. Okay, and so that's what that's how you interpret an EQA sheet, and you do that for all the different analytes as you go down. Okay, and so as you scroll down, you'll notice that there was an unacceptable performance for hematocrit. So let me zoom in here. So again, we have the name on the left. It says hematocrit as a percentage. And these are the 5 samples, FH10 or 11 through 15. You can see that for the first one, the mean performance was 53.9, and we came in at 55.8, so we passed because it's within the range here. For the next one, though, the mean was 31.5, and we came in at 33.5, and that's considered unacceptable because we're outside the high, the top of the range. Same thing for the next one. The mean was 29.4 with a range of 27 to 31, and we came in at 31.2. So again, we're just outside the range, but it was considered unacceptable. And when you come over to the right, this year-long summary, you can see that just like white blood cells, our hematocrit has been running a little high for the last 2 cycles, and now we failed. And you can see that there are these 2 marks on the right here, and that's a quick way to notice that you had some failures. Okay, so this is what a real-life EQA proficiency testing report looks like, and you can see we had failures in hematocrit and in MCV, and you can see it was the same 2 samples. So I mean, so hematocrit is related to MCV because for most automated CBC machines, the hematocrit is calculated based on the MCV and the hemoglobin. So it's not unusual that they will be connected. So as you go down, you keep seeing the rest of the automated tests. We also had problems in neutrophils, and we had 2 unacceptable results there. okay? And you can see, again, by looking at this year-long screen here, that we've had problems with this analyte, not just in the current challenge, FH10C, but in the one before that, the one B. So you realize, like, okay, we really have a problem with this analyte. And so forth and so on. So we really had trouble. We had quite a few failures in this one, which is unusual for this lab. The IDI core lab has like a 98% pass rate overall, but we were really having trouble with hematology at this time. Part of it is just very old instruments. You can see also, eosinophils, we failed 4 out of 5, okay? And I'm sharing this because I want you to see what a real world PT chart and performance looks like, okay? And then on the bottom, okay, let me pause here before I go to showing you the blood smears, the actual smears, see if there's any questions about that.
Yes, we do have a couple. So
okay.
The first one, similar to the last, but it's specifically asking for clinical chemistry, what the difference would be between rechecking and retesting.
Oh, I am not aware of any schemes for rechecking and retesting that involve clinical chemistry. They may exist, but I personally have never encountered them. I've only encountered them in the context of simpler tests. So malaria, smears, HIV rapid testing, TB, AFB screening, Pap smears. I've never encountered them in the context of clinical chemistry.
Okay.
Yeah.
And let's see. So their accrediting body wants to provide justification on the frequency of participation in PT schemes. So is there a recommended frequency, or does it depend on the analyte and the provider?
Oh, it depends on the provider, but most of them are the same. They'll send you, they'll pretty much, if you're running a lab, you should be enrolled in PT at all times, So that's just, it's part of the basic practice, I would say. But then once you enroll, most PT schemes, whether from the US, Australia, Africa, wherever, usually send no less than 2 challenges a year, and usually no more than about 4. So it's usually 2, 3, or 4 per year.
Right.
Actually, no, I take that back. The most I've seen is 6. Yeah.
Right, and then for labs that can't afford to be enrolled in an EQA program, does doing comparison of results with other labs pass as proficiency?
Yes.
Comparison. Absolutely,
yes. I would suggest that yes, and that's a great question. I would encourage you to just document it so that it's more, so one lab, so lab A selects samples that are blinded to lab B, and you send it to lab B, and you cross-check with them, and you come up with ranges that are reasonable for matching. Yes, that counts. Absolutely.
All right, great.
And I would encourage it, yeah. All right, so we've looked at the quantitative tests, but as you go down here, you can see that there are, let me zoom this so you can see the full sheet. You can now see on the bottom, there are different types of specimens. These are images. And so the first one, if I click it, it opens up here. Can everyone see this screen with the blood cells?
Yes, we can see it.
Okay, all right. So it opens up here. And so this is so when we enrolled for the PT, we got this picture and we had to say what it was. And these are platelets basically that they're pointing to, but this is part of the same hematology EQA. So it's not just showing you, it's not just the automated stuff, it's also the pictures. So I'll go through a few of these. So that one was normal platelets. This is lymphocytes. And these, of course, now we have the answers, but these you get without knowing the answers. Some of them are pretty straightforward, like you see. This one is a granular lymphocyte. And you can see, if you zoom in, you can see the reactive granules in there. And so this is part of the challenge. And you will notice that for these visual tests of visual cell recognition, we have two sets. So the first set, which I've been clicking on, BCP 21 through 25, are all graded. If you look over here on the right, oh man, sorry. This is why I sent you the files on you, so you'll have it on your computers later to look at. If you look on the right, it says your grade, and it says good. Okay, so these are graded. And then below that, they have some that are ungraded. If you notice here on the left, bottom left, it says blood cell ID ungraded. And these ones are just for your own proficiency and improvement, but they're not graded. So, you know, let me pick two of these. Let me pick the one that says the bands. So this is what we got. And we had to say what it was, and you know, obviously it's a band, but you can of course go give more detail beyond that if you want. But it was on ungraded, so it didn't matter beyond our own proficiency. In all labs I've been affiliated with, whether this one in Uganda, the IDI core lab in Uganda, or at Hopkins, we still review these ones even though they are ungraded, because it just helps us become better, right? So, but this is kind of what it looks like. So this one, the answer is monocytes. Okay. All right. So we've gone through this. So now I've just taken you through what you would do as a lab director when the results come. So you've gone through, you've seen you have a few failures, and the question is now what? So now what is we did an investigative report, and this is, to my mind, the most important part of doing proficiency testing. If you're not doing the investigation, in a way, you're undermining the purpose of the whole thing. Okay, so after we've done all that, we come to the investigation, and this is what it looks like. So this is a form. Each place has its own form. This is a form we used in Uganda at the core lab, and it's called a general investigation checklist form, but every different place can have a form like this. If you want to adapt or adopt this form, you're welcome to. Notice on the top, it has the same thing. It has the name of the lab, the EQA provider, the survey name, just details. And then below that, it has the things that had problems. So the specimen number was FH10 number 12, and an analyte, it was hematocrit, and the results we submitted were 33.5. And when we repeated it, so you must always, when you come back, when your results come back and you failed, you must repeat that sample. So you should store it, you know, while you're waiting. And our repeat results was still high, 35.9, while the peer mean was 31.5. Okay, so the question here is, do we have acceptable results, yes or no? And the answer is no, meaning even after we came back and repeated that results, we still failed, right? So it's telling you that the problem is real, because sometimes, you know, you just have a mix up, or there's a bubble, or it's a whatever, and it's not necessarily a real problem. It may be a specimen issue, but this is telling you, okay, there's something real going on, whether it's your instruments or your staff or your sample. We don't know. It's probably one of them, but this is saying that the problem is real. And you see the same pattern for MCV. We failed before, and we're even more extreme. Before we said we had a result of 79, now it's 87. And for this other sample, it was 79, and now it's 90. So we're not doing well. Same for neutrophils, same for eosinophils. So everything is in the same, going in the same, we still have the problems we had before. For 2 of the eosinophil values, we improved, but still for 2, we failed. And so we come to the next section, which is a root cause analysis. And I would encourage everyone on here, doing this kind of investigation is a lot harder if you don't have a form like this. So if you have a form like this, it really helps you to just, because then you just have to fill it out. Well, if you have to do it each time from scratch, it's just a lot harder to motivate yourself. So for the root cause analysis, we have questions that are already predetermined. So the first one is, were proficiency testing materials received in the lab without delay? Please describe any delivery issues. And this is, of course, very relevant to many of us that have labs where we have to, things have to be mailed to us. So the comment, it says, yes, according to the shipping schedules, the samples were shipped on September 18th and received on the 25th. And they were received in the lab at ambient temperature. And this means that the cold chain may have been compromised. So this is already suggesting that the samples may have an issue, not necessarily the lab. Okay. So second question, were samples shipped and stored appropriately according to temperature requirements? So we responded by saying samples were received at ambient temperature and not cold pack, but were stored at the fridge temperature on arrival. So when we got it, we put it in the fridge. So this whole, I won't read everything for you, but you have this in you received this. And I would encourage you to either to use something like this as a template because it helps you. Otherwise, it's just, as I said before, it's just a lot harder. It's much easier to achieve and maintain quality if you have templates and things like this that can help you along. So all this work, filling this out and doing the investigation is completed before I come back in, right? So I see the original, as a lab director, medical director, I see the original PT report, I see the failures, but then in between, our quality manager, which in this case was Mr. Mugabe, has gone through and filled all this out. Talked about what the analytical errors was. Again, this is just walking you through, did you pass QC at the time, what was going on, blah, blah, blah. And then at the end, actually not quite the end yet, but it talks about post-analytical errors. Was it a transcription error, right? So, and their comments are, results are keyed in by one staff member and reviewed by another before submission. So this is saying that it's likely not a transcription error. And so we go on, and this is the investigative actions and root cause. And I'm showing you this to show that this is a real investigative report. This is a standard we maintain, and this can be done, right? And it just makes your whole lab better and operate at a much higher level. I see a lot of questions coming in, so let me just finish this and then I'll pause for questions. Well, basically, again, you have this in your email, okay? So you can go through on your own, but it says we reviewed daily. What did we do? We reviewed daily QC. We did interlab comparison testing, which someone had asked of before, but basically we took some samples and sent them to our sister lab there on the hill in Kampala. We engaged the engineer. We repeated the PT testing material, and then he goes on to describe in narrative what we did, and what our results. We says hematocrit for only one specimen out of 5 did not compare with our backup lab, right? So that means all the other results compared very well with our backup lab. So what is this suggesting? This is suggesting that the problem was probably in the samples, the specimens, right? Because if we are getting the same thing in our backup lab, which is also CAP certified, Kampala is spoiled in a way because they have an abundance of CAP certified labs. If we are also getting the same thing, it kind of leans you towards thinking that this is a sample issue, not a lab issue. And we describe all this and we say here, the root cause of the EQA problem has not ruled out material deterioration during transit. This is similar to what was experienced during our last challenge, which is FH10B, blah, 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 blah. We also learned that other CAP 3 other CAP certified labs in Uganda that also participated in the same survey had similar challenges. So you do this whole thing, and then your director signs. So this is where I sign on the bottom. So I'll stop here and address some of the questions.
Okay, so actually on that last point, I'll jump down to this question. So there's a clinical chemist or a chemistry lab with experience with EQA where it was a worldwide EQA, so participants from all over. And it was discovered that whenever they were compared to the worldwide data, they noticed failures, but the same report when just compared with regional participants were within the same scheme, the results were acceptable. Difficult to do corrective action. Is there a way to mitigate such scenarios?
Exactly. So I think the way to do it is something, when you have a template like this, you can do that kind of investigation. Because what you don't want to do is to say, oh, we failed, but it's probably sample deterioration, without actually, doing due diligence. You can see here, we went back and checked our QC. QC was fine. We repeated the results. We checked with our engineer, and he did his function checks and so forth, and they were fine. We repeated the results. They were still failing in the same pattern. And then we sent our samples to a neighboring lab that we trusted, and they were getting the same results as we were. At that point, then I think it's reasonable to conclude, okay, these were probably affected by shipping. But I think we should resist the temptation to jump to that conclusion without doing the investigation.
Great, thank you. So a few other questions. We often do not have leftover samples to retest in unacceptable results. So how do you investigate for problems when you don't have adequate specimen volume to do retesting?
Oh, that's tough. So I would say to make it a habit to always have some EQA stored away. But sometimes you can't. Sometimes it's not stable or whatever. So I think one thing to do there is to do, again, comparison testing with other labs. That's one option. Or something we've done, but we don't do it often. The lab where I am now, I left. I don't know if many of you know, I left Johns Hopkins to run the laboratory portfolio for a company called Icon. And one thing we've done is for analytes that are hard to get, we try to create a large batch control and save it as aliquots in the freezer ourselves. And then so something like that can help, but likely mostly just comparison with other labs if you don't have the original EQA material.
All right, and so the next question is there a minimum number of labs that should be peered together for EQA results? So I guess, how big of a sampling of labs do you need to establish your ranges and have an effective program?
Yeah, that's a good question. And that question is especially good if you don't have, so with these big programs, UK NECAS, as well as all the countrywide programs, many of which are in different countries in Africa and throughout the world. I mean, Thailand has one, many countries have them. Those are fine because they have a lot of labs. But if you're in a place that doesn't have that, I would say try to get at least, well, two things. Number one, 2 is a lot better than 0, right? So if you can only get 1 lab, that's already way, way better. But if ideally you want to get at least 8. There's a lot more justification. There's a lot more explanation behind that, but statistically, you're more likely to have a better sampling if you have at least 8 in your queue. But more is better. More sampling is better. Okay. More labs, yeah.
So if you fail on hematology PT and you repeat testing the same sample and still get similar results, what more can you do? And they note that the NB control are passing.
Say it again, NB?
NB control are passing.
Oh, sure. I see. So it's like the controls are passing. Yeah, no, that's exactly the situation we had in this example. Yeah, I think all you can do is, so if you are a lab that's part of accreditation, then you have to document all this anyway for when you get inspected. So I think that's all you can do is what we did, which is you documented it really well to show that, you know, you've done your due diligence, you looked at QC, QC is passing, you've compared to other labs and so forth. And you've made sure that you don't have any intrinsic bias. I think that's all you can do. Document well and do your comparisons. Yeah, it's actually not that, it's not an uncommon problem, which is why I selected this this as a teaching example. Okay, any more questions, or should I?
We have a few more.
All right, keep going.
Okay, so this one I think is about the picture slide based example that you shared.
Yeah.
So they're asking, you know, if EQA is meant to check the entire testing process, you know, how are these picture-based ones really effective or applicable?
Yeah, so EQA, so it's tricky. There were some slides in this deck initially about all that, about how EQA helps with pre-analytic and so forth, but I took it out because I feel like that's not the main point. EQA, yes, can tell you about your whole process, but I feel like it really applies more to the analytic and post-analytic, but especially the analytic more than the pre. So yes, the person, his or her point is correct. They are correct that just sending slides doesn't tell you about, for example, pre-analytic. However, it's testing a different thing. Which is why, if you notice, the EQA, that form that I went through quite slowly, has both the stuff that tests your pre-analytic and analytic, as well as the images. So you need things that test the different parts of the process, right? So the images are testing your ability to identify and differentiate cells. So I think it's still important. But yes, you're right. It's not testing the pre-analytic part, but that's not always the point. So as this is especially through an anatomic pathology, when you're looking at, you know, when you get a slides for proficiency testing, usually you get a set of slides and you send in a result, and it's not necessarily testing your ability to make slides. So the histology portion is only testing the interpretive portion. And then sometimes you get some PTs, again, for anatomic pathology, that are only for the front end, the ability to make slides from a piece of tissue. I didn't go into that here because you'll see we have so much material, I couldn't get through everything, but yes, there's also a whole world of proficiency testing for anatomic pathology, which is just as, I would say, just as important. But we won't cover it in this lecture. And if there's really demand for it, we'll try to figure out how we can bring it, how we can fill in the gaps.
Okay, and we have a request for you to share the root cause analysis form, if possible.
I think, yeah, it's been shared. I think it was part of the, right, Dan? I think it's part of the email somewhere.
Okay, and I think some participants aren't getting those emails for some reason, but going forward, I'm going to make sure that I receive the cases as well, because as a participant, I'm not getting them either. But so anyone that hasn't gotten them, send your email in the chat window, and I can distribute after the call today. And I think the rest of the questions we can wait until the end and see if we have time.
Okay, awesome. Awesome. So we have gone through kind of what is EQA and I mean, what is proficiency? We spent a lot of time talking about proficiency testing. And now I'm going to switch gears a little bit. This is a little bit of a risk, but I think it will be useful. To talk about the history of proficiency testing. And part of the reason I want to do this is I think that there's a lot of benefit to understanding where these things came from and how come, for example, in the West, in the US, for example, pass rates are around a maintained around 98, 99% for all labs, not just, sort of specialty high-end labs. So for example, as I was showing, I worked as a medical director for the IDI core lab in Uganda for 6 years. And that lab also performs very well, but it is kind of a high-end lab within the African context. While in the US, most labs are performing at that level, and there are good reasons for it, and I wanted to try to share that. I hope that this is useful. All right, so the history. I left this in here because to remind me to share. This is a lecture I gave in China about they wanted to know about the history of how laboratory quality assurance in the United States was established. So I gave this in 2014. Okay, so let's start in the beginning. The first hospital laboratory that I know of was built in 1895, and this is the building. It was built by, it was called the William Pepper Laboratory of Clinical Medicine at the University of Pennsylvania. At the time, there was not really a field called pathology or laboratory medicine. There was just medicine, or basically internal medicine. And then at the time, physicians started figuring out that they could measure things in blood, for example, or in urine. For example, people who had multiple myeloma, you could look for protein in the urine and so forth. So they had just started figuring this out, and the University of Pennsylvania, this was sort of the birth of this initially was sort of a subspecialty before it became his own specialty. So 1895. So it took from 1895 to 1998 for the US to codify laboratory quality into law. So because CLIA came in 1919, the law was passed in 1988 and actually was applied around 1992. So I just wanted to show you that it took 100 years of sort of trial and error and bungling and so forth to get to that point, okay? So the current state of the clinical lab in the US is quite good. In general, things are high quality. Test results are overwhelmingly reliable and actionable. If you go to any hospital, it doesn't have to be a fancy one, and you get a result, you can trust it, which is not necessarily true in much of the rest of the world. Overall EQA pass rates, again, I'm not talking about fancy high-end places. I'm not talking about Hopkins here. I'm talking about any hospital. Around pass rates are high, around 99%, 98, actually more like 98. And deficiencies in annual inspections are generally low. There's also low fraud and waste overall in clinical laboratories. So things are quite good, and it's highly efficient compared to other health services. So overall good, and there's a lot of detail here that I'm skipping, but let's just say that overall it's quite good. Go ahead. So I'm going to tell you, how did we get here? So the first hospital laboratory was established in 1895, and after that, it started kind of spreading and popping up in different places. And then it took about 50 years until 1947 for the first laboratory EQA scheme to be set up. This was done what happened was in 1947, Dr. Belk and Dr. Sunderman, both named William, decided to do a survey of the accuracy of chemical analysis in clinical laboratories. I will point out that around the same time in England, there was someone who was doing something similar, but I'm going to focus on the American experience here. So in 1947, what they do was they took calcium and weighed it. So they weighed 6.6 milligrams of calcium and dissolved it in water and made aliquots and sent it to 17 hospitals. In Pennsylvania area. And what you can see here are the results. So the correct result is 6.6 milligrams per 100 mils, and you can see the results are all over the place. And this is as a table, okay? So they sent several challenges, and the maximum possible score was 7. And they sent it in September and October of 1947. And you can see on the left that no lab got 7 out of 7. Only 3 labs got 6 out of 7. And most labs got less than half correct, right? If you look down. The same thing happened again in October when they sent the results, the same pattern. And their conclusion was that there was an appalling inaccuracy in the measurements. Levels of acceptable performance among hospital laboratories were often in the 30 to 40% range. What's interesting is, based on my experience, again, with pathologists overseas sending out proficiency testing to hospital lab in various countries, 30 to 40% is about the range we see in places that don't have controlled quality, right? So it's interesting to note that at the beginning in the US, we saw the same pattern. So the question is, how did they improve? That's the interesting story. So the initial interventions to improve quality were based around people acting better. So from 1949 till the 60s, the labs were voluntarily enrolling in EQA schemes. So I'm using it interchangeably with proficiency testing. It's not necessarily accurate, but just work with me for this lecture, okay? So labs were voluntarily enrolling in these schemes starting in 1949, and by the 60s, about 2,000 labs had enrolled. But this, again, is quite similar to the way things are now in much, I would say, much of the global South, where it's voluntary, and it's just people that are trying to do better. So things improved in that way. The quality of the staff improved over time also. And by 1967, the National Bureau of Standards here in the US started making biomedical standards. Before that point, they were not making them. I want to point out here, just for context, that while labs did not have good quality at this time, the US had already fought in World War I and World War II and had trains and so forth. So this was a society that was already quite technologically advanced, but had not yet tackled the lab quality problem, okay? And I hope that this context is helpful for you to hear and understand. So basically what was improving was professionalism over time. And people who wanted to be better were trying to be better. Labs were voluntarily enrolling and so forth. So this is kind of what it looks like. It was a voluntary scheme, but from 1966, Medicare and Medicaid started in the US. So basically the federal government started paying for healthcare. And that's a big change, because from that point, they had more say in what happened. And what you can see is from that point, 67 until 88, just 20 years later, they changed things so that it was involuntary. So Medicare and Medicaid started in 66, and by 1967, which is just 1 year later, they realized, okay, we cannot be paying for low quality crap results. So they immediately in 1 year created the first CLIA, the first law that says hospital laboratories, in this case, only large hospital laboratories, so not all, only large ones, had to meet certain quality standards. So it really was about the money. So once the federal government started paying for care, they put in the law saying you had to meet certain quality standards, but this only applied to the big hospital labs. So most labs, clinics, and small private labs and so forth were excluded, which was the majority. Okay, let me skip that. Okay, so what about the rest of the laboratories? Well, they got brought in 1988, but what drove us there was between 1967 and 1988, there were many, many issues around fraud. And what I've labeled here are legislations designed to address fraud. Okay, and this is, again, this is the US system. And I'm hoping this is helpful to you to understand how did things get better. And they got better because there was a lot of fraud. And so in 1967, the healthcare fraud, I forget what it stands for, but you can Google it and figure out that's one fraud based or anti-fraud legislation. There was a no markup statute in 1980. Then there was a no markup statute plus Stark. So the Stark law in the US basically says, I cannot, which would I know would be controversial in many countries, but here in the US, I'm not allowed, say me, myself, Tim, is not allowed to, for example, own I'm not allowed to, me or my family is not allowed to own the laboratory. It's not allowed to perform testing for a clinic or hospital that I also own. Okay, so it's designed to discourage abusive testing, where you see your own patients, you test all of them, and you make all the money. So that kind of scheme, this is designed to discourage that. I could have done that a lot more elegantly, but that's the basic idea, and I won't go into much more detail than that. But basically, from 67 to 1980, over those 23 years, there was a lot of issues around fraud and legislation to address it. And finally, so there were fraud, waste, and quality scandals. And finally, in 1988, the federal government felt like, okay, we really have to this area of labs is really prone to low quality and fraud. And so let's just make a big law, not only addressing the big hospitals, but everybody. And so that's how CLIA 1988 happened. And just to show you the thinking in the years leading up to that, this is a cartoon from in 1976, if you see on the bottom. And you can see that the patient is the American government. You can see from the hat, he's Uncle Sam, and Medicare and Medicaid are doing surgery, and they said, there, I think we got it all. Close the wallet, doctor. So it's basically, at the time, the feeling was like, the Medicare and Medicaid were just taking all the money. And so there was a lot of drive to kind of come in and regulate and fix things. So I just go to section 2 here, item number 2 in this slide. If you notice this, I didn't change the slide from when I presented it in China, but if you go to item number 2, there are 2 main drivers of, I would say, of improved quality in the US. And one was just professionalism, which is labs with good people and motivated people trying to do better. And I would say that was from, the 1940s to the 1960s. And then from the 1960s to the 80s, finally, the late 80s, the government was itself fighting fraud and poor quality through regulation. And I think this is what I feel is that in many countries now we are still in the professionalism phase, where we expect people to perform well, to do the right thing, to have high quality just based on their own professionalism. And that's great, and it can work. But I think to be able to extend those high standards of quality and low fraud to the rest of the labs, I would argue that can only occur through some kind of regulation. But okay, so I've made my point. I'm sure there'll be a lot of comments about that. What has been the impact of this of these schemes, of the regulatory schemes, is what I started with. Basically, we have high quality, we have relatively low fraud and waste, and we have a highly efficient laboratory practice in the US. However, I will stress that low fraud and waste, number 2, does not mean no fraud and waste. So I will show you that similar to other countries in the US, laboratories are especially prone to fraudulent practice. Why is that? No, I shouldn't say they're especially prone to fraudulent practice. They are an attractive target for fraud. And why is that? Because laboratories are a volume business, right? So if you can get a small shilling out of every test or whatever, it compounds quickly. So I just put here some of the big fraud cases that we've had in the US. And this is by far not an exhaustive list. I just put a few for example. So in 1992, there was a $111 million judgment against National Health Laboratories. In 1997, $325 million. in 1998, 140 million. And one of the biggest labs still working in the US was fined 241 million in 2011 for overcharging. And many of these groups are actually quite professional, right? So Quest Diagnostics, for example, is a highly professional business. Same with Blue Cross and Blue Shields, but these things happen, and the laboratory system is especially prone to this kind of fraud because, again, as I said, it's a volume business. So I did want to point out that fraud doesn't only happen in sort of poor countries. It happens in the US too, and it happens at a higher, it can be high dollar amounts. But the overall level of fraud is low. And this I had shown during that lecture. If you remember the lecture, I was presented it in China in 2014, and I was making the point to them at that time that even a few weeks before I gave the lecture, there had been a large judgment against 2 doctors for false claim involving laboratory payments to the tune of $15.75 million. All right, so this is the end of the lecture part. I still have the cases to go over, which I think you'll find useful, but I hope you've learned the importance of an EQA program. I just went through the history of proficiency testing, and I think I discussed reasons why PT performance is much better overall in Western countries. And I'm hoping that that discussion will help us think about how we get there and how we can apply those lessons. And we also discussed the steps in participating in an EQA program, from enrollment to investigation of an unacceptable test results from an EQA sample. And we also learned how to read and interpret a CAP-PT result sheet. So here's the time for questions. I'll pause for questions, and then we'll do one of the cases.
Great, thanks. So first question is, so this participant is enrolled in an EQA scheme, and they received a note that they needed to take, so I guess the EQA material loses potency after 3 days of opening.
Okay.
So when they receive a result more than 3 days later, it's hard for them to do retesting because then the quality of the sample has degraded.
Yeah.
So is there a way to deal with that situation?
Yeah, I think so. It's similar to an earlier question, which is just in this case that you cannot use the sample because it's degraded, but you still have to, you still can, for example, compare results with local labs if you have local labs that are running that analyte. Another thing that I suggest doing is for analytes that are uncommon. Again, my experience here with, we have had to do this with cytokines, is when you get a sample that is especially high or especially positive or whatever you're looking for, is for you yourself to try to freeze it. And then in the future, you can always use that to sort of cross-check yourself.
Okay. Now, another participant, this is they failed PT, and the accrediting body wanted them to recall all results going back since the day that they analyzed that PT sample. Is that necessary? And because they say they depend on QC results to validate tests, not the PT results.
Yeah, this is a good one. Actually, before I came to this lecture, I was having my weekly meeting with one of our labs here, and we failed something. So the question was, should we recall our results? I think this is where you need, this is where the role of the medical director, if this was a US system, comes in, because you need, so I'll give you an example, the example from this morning, right before we came. We failed it was a very tiny, we're just outside the range. And when we went back, we noticed that there was a very small bias in when we went back to check in our QC. But I decided that it was not likely clinically significant, right? So we didn't need to go back. But this is where you do need, yes, both a technical expertise, but to take into account what the medical implication of that test result would be. But yeah, if it's bad, I would recall the results. I would, because otherwise it's just bad. You're giving people bad results, and I think no results is better than a bad results.
Okay. Now, in a case where you've run valid reagents but have expired ones, can you still go ahead and perform tests, especially that you've received samples for EQA? I think it's asking, they're asking if you can use expired reagents for EQA samples.
Yeah. This is a good question, but also a tricky one, because I'm supposed to say you should never use EQA reagents, and I've said that. However, I'm a practical person, so you should I think you can you can take from that what I think. Sometimes you just, a lot of places have real trouble acquiring reagents. Also, they can be quite expensive. So sometimes it does make sense to do if you are doing testing using expired reagents, then I would say it's probably appropriate to run your EQA also using the expired reagents. The only thing I would stress is we can't have, so there are all these different things designed to maintain quality, right? There's the quality of the reagents, there's QC, there's EQA or PT, there's all these different things. But we can't cheat on all of them, right? Because then we have no way of determining quality. But if, for example, we have a pretty good QC program and we know that, and we're passing, and everything else is in line, but the reagent is expired, and we have assurance that it's still functioning properly, I would proceed with caution, but I would proceed. I would.
Okay. Now, if you fail EQA and you do a root cause analysis and corrective action, when do you get assured that the corrective action is effective? Would it be the next EQA?
Yes. So this is
your QC, or?
Yeah, no, it tends to be like you have to, because also, yeah, you have QC and so forth, but ultimately you have to kind of wait till the next EQA. What I've done in the past, and yes, and sometimes waiting till the next EQA takes too long. So one practice I would encourage everyone to do is, once you get your EQA and you've run it, freeze it, right? So if you're able to freeze it so you always have it to go back to. That's number one. And then number two, one thing you can do, and I have done, so at Johns Hopkins Bayview, one time we had a terrible problem with our phosphate. We failed like 5 out of 5. It was terrible. But we went and fixed that. But we didn't want to wait, for like another 3-4 months before starting testing. So you can actually contact the accrediting agencies, whether it's CAP or UK NECAS or SANAS or whoever. A lot of times they will be willing or able to send you another batch of materials out of cycle, so you can get started. So that's one idea.
All right, great, thanks. So we also have a question on fraud and waste. So the participant understands the concepts around fraud, but they're not understanding where waste comes into play in that conversation.
Yeah, so that's a great question. It kind of requires a different lecture. maybe we'll set up another 10-week class, but all around the ideas of. So in the U.S. in particular, this is kind of a U.S. Centric construction. There are 3 things that the federal government in particular the Office of the Inspector General looks for, and it's fraud, waste, and abuse. And by abuse, we do not mean, say, domestic abuse, someone beating up their partner. That's not what we're talking about here. We're talking about abuse of a system. And all these things are considered, bad and illegal. So it's in that context that I'm using the idea of waste. And the idea of waste is what the federal government is saying. And I think it is a useful idea. I don't know how it would apply to other countries, but I think it is a useful idea. What they're saying is, yes, if you have a system that we may not be able to say, for example, that you're being fraudulent, you're actually, overbilling or billing for tests that you didn't perform, which would be fraud. But waste is also a bad thing. And waste here is not small. It's not like, oh, you ran an extra control you shouldn't have. That's usually not the level we're talking about. The level we're talking about are things where, for example, I'm trying to think of an example. I wish I didn't prepare any examples, so I'm just pulling this from my head. So forgive me if it's not accurate, but something like buying, for example, too much reagents and charging it to the government. When I say too much, I mean 2x or 3x or 4x, where you know that the reagents is probably being used for something else, but you can't put your finger on it. That is considered waste. Because it's the government would say, even though it's not fraudulent in the sense of you putting it into your car and taking it home, which is stealing, it's still considered wasteful. And they created this category, fraud, waste, and abuse, to be able to catch different flavors of fraudulent behavior. There's much more, and this whole topic is very interesting. Unfortunately, I don't have the materials. But I can maybe after this class circulate something that would address that. It actually is really worth thinking about. I think to really understand, okay, how do we, if we want to decrease corruption, it's not just about fraud, it's also about waste and abuse of the system. And I think, yeah, so that's where that comes in. Sorry, it's a long-winded answer, but basically it's a different way to capture. It's not waste in the sense of, oh, you should have used, 20, instead of using 20 pipens, you use 25. It's not at that level. It's just, it's addressing a much more significant intentional wastage of resources.
Yeah. And how long is the case going to be? We have a number of other questions, but I don't want you to run out of time.
Yeah, so the case, so I have two cases. I'm only going to do one because I see that we're running over. And the case is somewhat similar to what we did before. So I'm not going to, let's say the case.
Tim, this is Dan. Oh, yeah. Can you hear me?
Yeah, I can hear you.
Yeah, you've got 40 minutes, so you're fine.
Okay, good. So I'll do the case. Ken, the case will be like 20 minutes.
Okay.
Yeah.
All right, so we can come back to the remaining questions at the end of that case.
Okay. Okay. Yeah. Should have a fraud, waste, and abuse seminar series. All right. So the case, I will now do the second case. So I will warn you ahead of time. This case is a little more complicated, or maybe a lot more complicated than the other one. But I'm doing it because I want to show a diversity of what PT looks like. Okay, sorry, I didn't think about this one too well. Basically, this case has questions associated with it, and I need the questions. So, Ken, I'm not sure if it's possible for you to read the questions. So to me, I can go back and forth. Okay, so let's see. The first question here is, what is proficiency testing? We've already answered that. The next question is, how many panels were in this PT challenge? Okay, so let's go over here. So this is, I wanted to share this just to show you a different type of PT results coming in, right? So I showed you one from CAP, and I wanted to show you they come in different flavors, but usually they have the same kind of information. This is for you can see up here, it's a HIV RNA proficiency testing. That's what it's for. And at the top again, you can see the lab is lab 0304, which is in Malawi, Blantyre. This was my other lab on the JHU, which was in Blantyre. And so the question was, how many panels? And so this is what you see. But if you go through, you can see that if you just look at the way it looks, you can see that there's kind of 4 pyramids here, right? Where the nominal concentration goes from 0 to high, 0 to high, 0 to high, 0 to high. And so just by looking at that, you can see that there were 4 panels, okay? The second question is how many samples were in each panel? And I wish this was live because then I would let you guys answer, but unfortunately it's just me. And you can see here there are 5 samples in each panel. So there's this sample with nominal concentration of 0. There's one with nominal concentration of 50. There's one with 1700, blah, 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 okay? Let's see the next question. Question is, which column in table 1 is the target and which is the laboratory's results? Okay, which column is the target? So you can see here that there are 5 columns. So first one is called panel ID. The second one is called nominal concentration. The next one is called log 10 nominal. The next one is called exported results. The next one is log 10 exported results, blah, blah, blah. So what I'll tell you is the first 2 columns come from the EQA provider, right? So these 2. So they're telling you that this sample, RNA 033RT.10A, and if you notice the numbers go, from 7, 8, 6, 9, 10. So number 10A has a nominal concentration of 0. So these first 2 columns come from them, and the next 2 come from the lab. So the lab reported the first one as not detected, which is appropriate for 0. And it reported the second one as also as not detected, and we'll discuss whether that's appropriate or not. And then it reported the third one as 1096, which is versus 1700. But we are not judged for this or for many PCRs by the numerical results. Rather, we're judged by the log 10 results. And here you can see our log 10 is 3.04 versus a log 10 of 3.23. So it's pretty close. And then here on the last column, it just shows you the log 10 difference, okay? So this is how this is set up. On the top here, it shows you, it says table 1, data used in scoring Abbott MR2000 RT assay. The MR2000 RT, as you know, is the platform. And the kit here is AR. And when you go down, it tells you what AR means down here. It says 2 characters for kit. RT equals Roche-Tachman. IH equals in-house assay. ME equals whatever. AR equals Abbott real-time assay. And GX equals Gene Expert assay. So all this information you've input in the beginning when you enrolled for the EQA. Again, I'm showing you this just to show you that EQAs, the reports can look very different when you get them, and you just have to, the first time you go through them, usually it will take, at least for me, it takes 1 hour to 2 hours to really understand what is this and what is it telling me, and you just have to invest that time. And then the next time you get them, it'll be, you can just go through and review it in 5 minutes. Okay, so we have 4 panels of 5 results each, okay? And let's see. Let me see here what the next question is. I have here, how does the MR2000 work? How does it detect and measure nucleic acids? That I won't answer, that you can find on Google. But this is something I use for teaching. So those of you on this course who teach either students or residents, feel free to use this for your class. It's a way to teach about EQA, and it's already all set up. Let's skip to number 8. Why are some of the samples with a nominal concentration of 50 reported as not detected, while some are reported as actual numbers, for example, 93? So let's go back. So here we have a nominal concentration of 50, and our lab reported it as not detected. While down here, we have another with a nominal concentration of 50, and our lab reported it as 93. And so the answer, usually I would wait for the residents to try to figure it out, but the answer here is because in Malawi at the time, I don't know if it's still true, but in Malawi at the time, we were following the WHO's reporting standards for HIV viral load results. And the standards were designed, were established at a time when platforms were not reliable below about 200. And so the directive was not to report results below 100. I mean, sorry, below 50. No, was to be 200, below 200, and then it got revised to below 50. So at that time in the lab, anything below 50, if we got a number, we just said not detected, even though in the lab we actually had a number from the instrument. So that's why. All right, let's keep going. So it says, why do we use log 10 transformation to study certain molecular assays? And the answer is because molecular assays tend to be, have much less precision than say a chemistry assay. And log 10 allows us to compare our results in a more meaningful way. Because if I get a result of 1,700 and someone else gets a result of 1,200, clinically there is no difference. But those numbers are very different. So one way to kind of correct for that with a lot of molecular assays is we use the log 10 results. All right, so it says, what is the meaning of figure 1 and table 2? Figure 1 and table 2. So scroll down. Again, you have this in your, it was sent to you, so please feel free to go into detail and feel free to use it for teaching if it serves you. Same for the hematology one. Figure 1 and table 2. So this is table 2, and let's see figure 1. Okay, so this is what I was saying. So figure 1 and table 2 are showing the same data. And basically, it shows that, actually, let me go to the figure 1 because it's easier to describe. So figure 1 has on the y-axis the mean log 10 recovery. That's kind of how it says, did you recover what we expected you to recover? Okay, and it's normalized so that all the labs, the mean of all the labs is close to 0. So you have it there, and then this is in blue is what is our lab's performance. And what you see here, 33-2, 33-3, 33-4, and 35-1 is showing you different challenges over time. And so you can see that overall, we have been slightly below the mean of all the other labs in our recovery. And we just, in this challenge, caught up to them. And the other table is showing more or less the same results. Okay. Okay, there's a lot more detail here, but let me just summarize and let me just summarize. So I think this, I've made the point already that this is quite a different scheme from the hematology one, but there's enough here for you to review on your own. And again, as I mentioned, feel free to use this for teaching. It's already set up. But what I'll show you, I'll just skip ahead here, is if you read through this, it tells you, how to interpret the results. This figure is the same as this figure, just shown in a different way. This shows you, just shows the actual results as opposed to just this figure showing just the means. Okay. And then in the end, you can come over here and tells you how you performed. So this says we had our official score, which is here listed as OFF score, which our official score is C, and C is passing, and that's somewhere is defined somewhere else. If you go through the document, it defines what C is. So, sorry, I'm scrolling fast. So our official score is C. We also got an unofficial score, which is PC, which is a provisional pass, essentially. And if you go into detail in my questions and in this document, it tells you why we got that provisional. It's not that we failed, it's just something about how they do the statistics, but our official score is C. And so for the point I'm making here is for different types of EQA schemes, the results come to you very differently, and you just have to take the time to learn how each of these work. For UK NECAS, I'm familiar with UK NECAS for CD4, CD3, CD4, CD8 monitoring, and those, again, the appearance is very different. The Australian one, RCPA, is very, very detailed, but also appears very different. But most of these reports have a lot of value in them if you take the time to go into it. So that's kind of the point here. I will stop here showing this report and just take questions until we're out of questions.
All right, thank you. Okay, so we have a question about an AP rechecking scheme. So this was a laboratory that had a FFPE tissue block that they sent to the US as PT.
Okay.
The paraffin was of poor quality because of where they are. It's they're unable to get the best histology grade paraffin.
Yeah.
So their result from the PT provider was poor paraffin. So basically they couldn't assess it. So they're asking, I guess, what other options there might be, or whether providers could be more flexible with labs from countries where reagents are not ideal. What do you think this lab might do instead?
Man, these are tough. So I think, so
I saved them for the end.
So I mean, I think part of the feedback that these results are giving you is useful, right? Which is the results are telling you that there's a problem with your paraffin, which you probably already knew. I don't think it is up to the EQA providers to change their standards to help. I think it's up. It shows that we have a problem, and we just have to try to fix the problem. A different answer, which I've often thought about, is it would be so helpful to have EQA providers that were either local. When I say local, I mean Africa here, but it could apply anywhere else. It could apply to Asia or anywhere else. They were either local and or focused on the local market. Something, and to my mind, there's no reason why it should be so hard to do, except maybe no one has really focused on it as a business. EQA material is, we know, when I say we, I mean the field, knows generally how to create these materials. Yeah, so maybe that's the big long-term answer, is to have a local provider, because then that avoids a lot of these issues around transportation and so forth, which has come up a few times, and which you saw that even the lab in Kampala, which is a very, very good lab, also had problems with.
Thank you. So the next question is one specific to HIV viral load testing. They note that clinical decisions are made regarding the 1,000 copies per ml threshold,
Mm-hmm.
For medication switch and whatnot. But
Yeah.
Let's see. But with variation in molecular quantitative testing, is it not misleading to use log in evaluating accuracy of the testing platform? And it covers so much of the variations in the results obtained.
Yeah, it does. So of course the log Yeah, I mean, so this person has a clear understanding of it. I mean, then they make a good point. There's no, I think the log is just a practical solution. Honestly, it may not be the best. And if, yeah, so what you're pointing out is in fact correct, that using the log does cover over a lot of imprecision. That's kind of the point. I think the key though is for use in the local lab or in the local hospital. Of course, we don't use logs; we use the actual numbers. Yeah, but they're right. I have no. It does cover up imprecision, but it's also designed to cover up imprecision because the providers of the EQA have decided that that those changes are not significant. But one could also, like, for example, within your own lab, you could decide that no, these changes are significant and we need to pursue them. But that's more, but the providers of the EQA decided, so it's an intentional choice. But yes, you're right. Your point that it covers over imprecision is correct.
Okay, and we have another question about recalling results after failing PT.
Yeah.
So if this is happening on I think if failing PT is happening on a regular basis, you know, what happens with patient management as a result of that? You know, if I think I think they might be asking, you know, if patient management decisions have already been made.
Yeah. So yes, exactly. So I will tell you from my personal experience, because I think that'll be enlightening. So I think if you're just starting to do PT and your pass rates is like 40%, I wouldn't start recalling stuff because it's just too much. But if you're already pretty well established, so I will give you two examples. I already talked about the phosphate failure we had a couple years ago. So what I did, I don't have that email, otherwise I would share it. I went through and looked at which clinics, because there was such a bad failure that I decided, instead of recalling results, what I did, and yes, the patient had already left, right? So it was in a way useless. So what I did was I looked at which clinics were ordering phosphate the most. And so this is where it helps to have good records. So we had good records. So I was able to find those clinics, so that we had at Bayview at that time, we had a bone disorders clinic. They were ordering a lot of phosphates. We had a clinic that was helping patients with, the oncology clinic was ordering a lot of phosphates because of multiple myeloma, and also people with osteoporosis. So those clinics, I then contacted those clinics personally by email and said, listen, we have this problem. It was probably going on for a month. This is just to let you know this. We've identified it and we're trying to fix it, and so forth. So we didn't recall it, but by taking that action, it just made the physicians trust us more, which is one. I've done this now that I'm thinking about it, at least twice. So I did this for potassium. I did it again for calcium. One time we're having issues. And I have never had the doctors say, oh, you guys are a terrible lab. Always they're so grateful. And it just increases trust, because we're able to say our phosphates were unreliable. We're not recalling the results, but we just wanted to let you know that we think we have a problem, and we stop testing until we fix our problem. And in my experience, that has always been received well. So yes, so I've done both recalling results, especially for trials, for studies, clinical trials. Then I think it really matters. But in the context of a real day-to-day hospital, we did not recall the results because of exactly what this person said. It wouldn't matter. It was already too late. But what I did was contact the clinicians.
All right, thank you. We have two other questions, but one I'm having a hard time understanding the question, and the other is a little bit more related to certification accreditation. So maybe if you'd like to look at those offline and respond to the participants after
Okay, so let's see. However, like high RPM change the result, but with difficulty. Oh, okay, so this is, okay, AQA is there a certification and credit? Oh, okay, so I can answer the certification one. So certification and accreditation are quite different from EQA. So you can have a lab, for example, a 1-star lab in the SLIM test system is supposed to be enrolled in some kind of proficiency testing, EQA, but that lab is not yet accredited, right? So, and I think Jeanette Guarna did a whole lecture on certification and accreditation last year, but basically, accreditation is that you've met some standard, usually of quality, for the clinical lab. EQA has to do with the system of testing blinded samples, and enrollment in EQA is required for accreditation, but they are not at all the same thing. You can have a lab that is not accredited, but that participates in EQA. So for a lot of labs that are 1-star, 2-star, 3-star, 4-star, or even 5-star before accreditation, all those labs participate in EQA or proficiency testing, but may not be accredited. And then the last question I also had trouble understanding, so.
I think that wraps up the questions then.
Okay.
There were 5 people that did not receive the case or your root cause analysis template, but
okay.
Dan will be emailing those files out to
They already have it.
Oh, perfect.
That's quick. All right, thank you, everyone. I hope this was useful. I decided to go much more practical than theoretical. So I hope that was useful to you, and I hope the discussion of the history of quality in the U.S. was useful to you also. Thank you.
All right, thank you, everyone. Do you want me to help with the Q&A, or do you want to go through those questions yourself?
Oh, me, Tim?
Yes.
I would love your help.
Okay.
Yeah.
All right. So Tim, you need to share your screen again because I'm going to start the webinar.
Yeah, I will. Just making sure the other stuff is queued up so there's not too much delay. All right, I am ready.
Okay, so I'm starting the webinar. So we'll give people a few minutes to come in.
Yeah. Oh, it's interesting on this side. I just see my screen. I don't see the participants. So it's very different.
Interesting.
Yeah.
Okay, well, I'm going to go on mute, but once we get to the Q&A, I will read through the questions.
Okay, and you can interrupt me in between if you'd like. In fact, I'd prefer that.
Okay.
Yeah.